The following episode is brought to you by the American Urological Association. The American Urological Association is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. For more information on how to claim CME credit or to view faculty disclosures, please visit the AUA University at auanet.org/university. Support for this episode has been provided by an independent educational grant from Merck Co, Inc.
Good afternoon. My name is Jay Rahman, and I'm professor of urology at Penn State Health and chair of the AUA's Office of Education. It's my pleasure to host another episode in our educational podcast series, with this being one of several different podcasts in our broad series called Expert Exchange in Genitourinary Cancers. Today's specific show is titled Hereditary Kidney Cancer Syndromes, and it's my pleasure to have as our guest Dr. Mark Ball. Dr. Ball is an associate professor of urology, as well as an associate program associate program director of the Urologic Oncology Fellowship at the National Cancer Institute. His clinical and academic focus is on hereditary kidney cancer syndromes. He's published extensively in this space and has also operated quite extensively as well with over 1,000 different patients over the last few years that he has treated with these disease processes. So, Mark, first of all, big thanks for joining us. Really a pleasure to have my opportunity to pick your brain on an area of your expertise over the next half hour or so.
Dr. Rahman, thanks so much to you and to the AUA for having me today. It's really my honor and my pleasure.
Super. So maybe before we dive into some of the details, just maybe run through with us and our listeners some of the different areas we're going to be covering. And then obviously we can maybe tackle each one of those and go into them with greater detail.
Absolutely. I think we can start off by talking about who exactly needs to be screened for a hereditary kidney cancer syndrome. And there are a few criteria we can dive into. And some of the implications, both for the patient and their family members, for patients who undergo screening. And then from there, we can talk about the von Hippel-Lindau syndrome as sort of the syndrome that we base a lot of our other recommendations on. It's sort of the best known and the most common. And then from there, we can go into some case studies that really illustrate some of the points we'll be covering.
That's super. I think it's sort of a great way of looking at this. And obviously, I feel like although we have learned so much more about kidney cancer itself, I feel like, VHL is probably, what we all learned even, and I remember Dr. Linehan giving lectures at the AUA Basic Science Review course, even when I was a resident, and that was sort of the one we would always talk about. And then obviously our knowledge has expanded dramatically on a lot of the other hereditary type kidney cancers and mutations that are involved with them. So maybe just starting off, I mean, you sort of said, who should get screened? And I think this is, whether or not you have a practice that's rich in hereditary kidney cancer, I feel like these are the areas that all urologists and urologic practitioners should be familiar with, which is who should we be thinking about that should get screened? What are some of the criteria that should be used? So maybe walk us through that a little bit.
Yeah, absolutely. And thankfully, this is an area that we're seeing being incorporated to sort of the guidelines for our society and for others as well. So there are a few criteria that we can use to say this person needs hereditary kidney cancer screening. And that's really germline testing is what we're talking about there. The first is a patient who has early onset disease. And that's really defined here as kidney tumor at age 46 or younger. The next one is for patients who have multiple kidney tumors. So we call that bilateral multifocal, either a kidney tumor in each kidney or multiple tumors within the same kidney. The third is a patient who has a family history of RCC. And really, we're talking about a first degree relative here. So we're talking about parents or siblings that have RCC. And then the last one, and maybe this one's the most obvious, someone who has other sequela of a syndrome. So if a patient has kidney tumors, but they also have a hemangioblastoma in the spine or brain, that makes us think of VHL, that person should be tested.
So I think what you're sort of highlighting, very much is obviously we've got the patient in front of us, and there are certain variables you can pick up on that patient. Obviously, their age. You'll be able to know maybe from your own personal history with them or their imaging. Do they have multifocal tumors? Do they have bilateral tumors? But I suspect an area that we probably don't do as good a job in as we should is some of just the basic elements of family or familial history, right? I sometimes get the sense that not intentionally, but we dive right into this patient and their renal mass, and I think your point is that we probably need to take a step back and do what we should always be doing, which is take a good history. Is that an accurate statement?
That's absolutely correct. I have a patient that I operated on a couple days ago who presented with gross hematuria, who was almost sent home from the ER with some antibiotics for cystitis until he said, this is the same thing that happened to my mom, and she was diagnosed with a kidney tumor, and he also has a hereditary kidney cancer syndrome, and that's how it was picked up. And so a good history can really unlock that diagnosis. Absolutely.
And then maybe just practically speaking, when we talk about family members with a germline mutation that gives you a clue of kidney cancer, what are the different testing? How are the assays done? Is it, what sort of multi-gene panel is being used? Is there a kidney cancer specific one? We've obviously done a lot on prostate cancer, and we know that there's an array of genes associated there. So talk to us a little bit about the practicality of how this occurs and what are the panels that are really being run in most practices.
Yeah, so thankfully, it's easier now than ever to perform this testing because there are a number of commercially available hereditary kidney cancer panels from a number of companies. They tend to have 15 to 20 genes that are associated with hereditary kidney cancer syndromes. Some of those also have upper tract genes on there as well. But those will cover all of the known hereditary kidney cancer syndromes. They're CLIA approved. They're not research. They're often reimbursed by insurance, and it's really not an issue to order those.
And then just sort of related to that, are there any instances where you would ever, just practically speaking, ever do like single gene panels, or is that really is there a targeted reason for that? Just maybe give us your thoughts on that.
Sure. I think that the best reason to do that, if you're confirming a diagnosis for a family that already has, say VHL, for example, the father has VHL and they want to screen the children. There, you don't need to do a multi-gene panel. It's just a yes or no. Does this patient also have VHL? So really, that's the only time to sort of do that. Or if someone has a clinical picture of, say, they have a history of pneumothoraces and they have multiple renal tumors, and it looks clinically, they meet the clinical criteria for Birt-Hogg-Dubé syndrome, then you could also just test for a single gene for the folliculin alteration. You wouldn't have to do a multi-gene panel. Most patients, it will be a multi-gene panel. Okay.
And so we've talked a little bit starting off on VHL, and I think as we're talking about, I think that this would be a great one to really sort of think about the disease itself, and then I think that will hopefully lend us to probably maybe some of the most well-suited or well-discovered paradigms for treatment, and actually even new stuff that is out there for the VHL management. So talk to us a little bit about VHL, and knowing that our audience is a broad array, maybe even start as simple as, basic inheritance characteristics and things like that.
Sure. VHL, von Hippel-Lindau, is a multi-organ cancer syndrome. Incidence is about 1 in 35,000 live births. It is a autosomal dominant inheritance pattern, and it's caused by an alteration in the VHL gene, which is on the short arm of chromosome 3. it's interesting that that alteration is also the one that is found in the vast majority of sporadic clear cell RCCs. Of course, that is a somatic alteration in those cancers, and we're talking about germline in someone that has this syndrome. Now, patients with VHL, the clinical diagnosis is usually pretty straightforward because they have an array of features that really you don't see outside of VHL. These patients get hemangioblastomas. These are benign tumors of the brain and spine, but they're very vascular and they can cause morbidity. They get retinal angiomas. These are vascular tumors, tumors of the eye. They can cause blindness if they're not detected and treated early. These patients can get pheochromocytomas. They can get pancreatic neuroendocrine tumors. And then the thing that we see as urologists is they can get renal cell carcinoma and renal cysts.
And talk a little bit about, in this VHL population, the renal cysts and renal cell carcinoma, just maybe, does your approach change at all when you're looking at, cystic renal lesions in this patient population versus the general population with cystic renal lesions that you're concerned for RCC, cystic RCC?
Yeah, absolutely. When we think about the sporadic population, someone who comes in with a cystic, maybe a complex cystic mass, those tend to be rather indolent tumors, and they can be observed when they're small, maybe. A lot of them eventually undergo some type of treatment. That is sort of similar for VHL, but we sort of have a trigger here for VHL of when to intervene, and that is when these tumors get to be around 3 centimeters. Now that's really for solid tumors, but really for complex tumors, complex cysts, it's really the same thing. If the solid portion gets to 3 centimeters, that is a time that we can sort of balance the risk of having low metastatic potential, but not intervening every time there's a small abnormality, because we know these surgeries get more and more complex the more times we go in and operate on these patients.
Yeah, so talk a little bit about, let's talk about surgical treatment, I guess, in part. And then obviously, I think we'll evolve a little bit to talking about, new horizons in medical management. But you alluded a little bit to the 3 centimeter principle, but probably juxtaposed with that is, this patient population with likelihood of recurrence as well as multifocality, the concept of partial versus radical, and then the inherent potential for reoperative surgery, which I guess over the lifetime of following some of these patients becomes perhaps part of reality. So maybe talk to us about all three of those: 3 centimeter rule, kidney preservation, partial versus radical, and obviously how do you manage these tough cases where you have to go back in and reoperate?
Yeah. Yeah, this is the stuff that we think about sort of day and night here. So, years ago, we saw that these patients just keep making new tumors throughout their lifetime. So there's a balance. You can do a radical nephrectomy up front and obviate the need to go back in. But obviously, if you do a radical nephrectomy on one side, they get tumors on the other side. You do a radical nephrectomy. Those patients are in dialysis, and that has a lot of morbidity, and we don't have enough kidneys for everyone to get a transplant, so that's not really a viable way to treat most patients, although some do end up there. So really a sort of threshold was made to operate when the biggest tumor gets to be 3 centimeters. Why is that? Because when patients came in with tumors that were 3 centimeters or less, we never saw a patient who had metastatic disease at that size. And that was really just based on kind of small numbers, empirical data years ago, but that threshold has really stood the test of time. We've, to this day, have never seen a patient with VHL who, when they had a tumor that was 3 centimeters or less, went on to develop metastatic disease. If we look at larger sizes, we see that there's a stepwise increase. When a patient is referred to us that has a 5 centimeter tumor, there's a % risk of having metastatic disease at some point after that, and it keeps going up the bigger the tumor has. So 3 centimeters is a convenient kind of rule of thumb. Once that patient has a 3 centimeter tumor, we go and sort of clean out all of the tumors in that kidney. And what I mean by clean out, we're doing partial nephrectomies and really tumor enucleation here, because you can't really take, if you take a margin for every tumor, then there's eventually not going to be enough kidney left. But we do know that these patients, despite a thorough clean out, usually 5 to 7 years later, start having new tumors in that same kidney. So a lot of patients will need multiple partials throughout their lifetime. And reoperative partial nephrectomy can be challenging. There are a few things that we try to do to make it less challenging. We try to kind of preserve Gerota's fascia and the perinephric fat. We reapproximate that over the kidney. So when we go back in, the kidney is not fused to the bowel or the spleen or the liver. Oftentimes we use ureteral catheters to help identify the ureter in the reoperative setting, because it can sort of be displaced medial or lateral, not in the where you'd typically find it. And then I really use ultrasound a lot in these reoperative cases to not to just identify the tumor, but also to identify the hilum, because it can be kind of really scarred in after it's been dissected 2 or 3 times before. So those are really my go-to tips to help navigate a redo partial nephrectomy. And then you asked about radical nephrectomy. We really reserve those, really only do them if a patient maybe presents with a large tumor, a large central tumor that is invading the venous system, or just makes it a difficult, there's not enough viable parenchyma to make it worth it preserving that kidney. But we really reserve those. Those are the exceptions, not the rule, for the management of VHL.
So for a very long time, as you eloquently stated, the mantra in VHL patients has been surveillance and then operative intervention at threshold 3 centimeters, with the goal of addressing all potential, or potentially trying to address all kidney tumors, not just that index 3 centimeter lesion. And so, now obviously, belzutifan is available, and it really presents, another alternative to integrate into the treatment paradigm. So talk about belzutifan. What is it? How does it work? And then how do you kind of put this into your practice in the VHL population?
Yeah, absolutely. Belzutifan is probably the most exciting development in the management of VHL over the past several years. And belzutifan is a HIF2 alpha inhibitor. So when we think about what's going on in the cell with VHL, sort of the first hit is there is HIF2 alpha is a transcription factor that is turned up in the absence of VHL. And a lot of the downstream effects of HIF2 alpha have already been drugged. Things like VEGF and a lot of the TKIs target things that are downstream from HIF. But HIF is that first domino that falls in the VHL pathway. So it was FDA approved a couple of years ago for management of patients with VHL-related tumors that are not quite ready for surgery, because in the early stage, you want to do what's tried and true for patients who need it. But it shows very promising results. The majority of patients who are treated with HIF2 alpha have a positive response. They have either stable disease or shrinkage of tumors in the kidney, in the pancreas, and in the CNS. So it's really changed the way we practice. We treat a lot of patients now with HIF2 alpha drugs when they meet sort of the following criteria. They don't have a tumor that's large enough for surgery. I have seen patients referred who have had large tumors, who are trying to maybe spare during a radical nephrectomy or something like that. It doesn't, in my experience, doesn't work too well when a tumor is too big or too advanced. But if a tumor is less than 3 centimeters, 90% of them are going to have an objective response, either stable disease or shrinkage. I tend not to use it in patients who are in their kind of early 20s, kind of reproductive years, because we don't know sort of long-term implications of this type of drug for someone who is still in family planning. And I don't use it for a case where they have a really mild phenotype. In other words, they might have one kidney tumor, and that's their only manifestation of VHL. It's hard for me to commit a patient to a lifelong, potentially drug with some side effects when a simple one-time surgery might do the trick for several years. But I think the ideal patient is one where the risk benefit is that surgery wouldn't be so simple, either because it's in the reoperative setting or they have a tumor that's in a bad location, or they have multi-system involvement. Maybe they have a CNS lesion that is growing and is worrisome to our neurosurgery colleagues. It might cause symptoms soon. They have growing kidney lesions or pancreatic lesions, and you can really get a lot of bang for your buck by using this drug to treat all of those at the same time.
Just and that was very well covered. Just a follow-up question: can belzutifan be used in sporadic clear cell RCC? Is there any data on it? I know this is a little bit tangential to what we're talking about, but just maybe your thoughts on that.
Yes, so it has been studied in the metastatic setting, and even among patients who have been heavily pretreated with other drugs, there is activity for belzutifan in the metastatic setting. And so begs the question, could it also be used in the localized setting for sporadic clear cell? It's not been studied in that setting yet, but I think there's no reason to think that it wouldn't have some efficacy. It's just really, we don't have data though to say how well it would work and how it would fit in with existing sort of active surveillance and intervention protocols for sporadic RCC.
So when we think about kidney tumors, and we specifically think about germline genetics, all kidney tumors, irrespective of size, are not necessarily created equal, right? And so your approach may be vastly different for a 2, a 3, or a 4 centimeter tumor. Thresholds to operate, margins with which you operate. And so talk to us a little bit about how you kind of take this information that you get from germline genetics, and you not only use it for informational purposes of their hereditary risk, but obviously as a surgeon, you take that information and translate that into how you do your surgeries or how you approach these patients. Talk to us a little bit about that. Give us some examples maybe of scenarios that are different, that you may alter your treatment plan based upon their disease genetic characteristics.
Yeah, absolutely. We talk a lot in oncology about precision medicine, about how doing DNA tests might lead to using different chemotherapies for people with metastatic disease. But we're really doing that in localized kidney tumors for those patients with hereditary syndromes. I can give some examples. When we operate, we've talked a little bit about the active surveillance and the 3 centimeter rule. And we use that, like we said, for von Hippel-Lindau. We also use that for a number of other syndromes, including Birt-Hogg-Dubé, BHD, and hereditary papillary renal carcinoma, or HPRC. For all those, we do active surveillance. We wait till something is 3 centimeters, and we go in and we operate. But we know we can't do that for every hereditary syndrome. 2 in particular. There is hereditary leiomyomatosis and renal cell carcinoma, better known as HLRCC, as well as succinate dehydrogenase deficient RCC. And these 2 syndromes, tumors can be very aggressive when they're small. We've seen patients present with positive nodes and even metastatic disease when tumors are in the 1 to 2 centimeter range. So for that reason, for those syndromes, we don't do any active surveillance. If we are screening a patient and they have a new solid tumor, even if it's small, we go in right away and we operate. So in that case, when we operate is different based on the genes. Now, the type of operation we do can also be different. So for those same syndromes where we do active surveillance, we also, that's VHL, BHD, HPRC, we do tumor enucleation. These are really well encapsulated tumors, and we kind of find that natural cleavage plane between the tumor and the parenchyma. We really take minimal, if any, margin. And those patients do really well with that approach. Contrast that again to those where we don't do active surveillance, the HLRCC tumors and the SDH patients. For those, we do not do tumor enucleation. We do partial nephrectomy with a wide margin because they can be infiltrative into the renal parenchyma, and that's the way we can safely get it all. And then the last thing I'll kind of say about that is for HLRCC and SDH, we'll even take it one step further. We often don't do robotic surgery, or at least not routinely for HLRCC and SDH, because they both have a propensity to have, if they're violated, then there can be carcinomatosis. There can be a really high risk of local recurrence, and we feel that an open approach for those is they're better suited for that.
And is this for partial nephrectomy or radical nephrectomy, or either of those scenarios?
They're for partial nephrectomy. If we're doing a radical nephrectomy, I think there's no problem with a minimally invasive approach.
So let me pick your brain on a few different cases just to get your thought process on how you would manage these patients, what goes through your mind, and maybe what you can help educate our audience on. And I think some of what we just talked about understanding and recognizing that all kidney tumors are not equal, all kidney cancer is not equal. So how you think about the disease a little bit differently based upon both presentation and genetics. So first one I'll ask you is, let's say a patient has multifocal tumors, and as you alluded to, recommendations are that patient with multifocal tumors should have germline testing. And let's say the germline testing is negative. So multifocal tumors, germline negative. What's your approach? What's going through your mind? What's your thought process on management?
Yeah, this is one we see often, and I think this is probably a common one that a lot of urologists, or at least urologic oncologists, see. And we sort of use the VHL paradigm for these patients. In other words, we try to do nephron sparing surgery. We may or may not use that 3 centimeter threshold, but we certainly don't have to go in if they're a 1 centimeter tumor. We may not wait all the way to 3, but we do treat it like VHL, and that we do nephron sparing surgery. The scenario that I see too often is someone will have 2 small tumors and they reflexively get a radical nephrectomy. The problem with that is, if a patient has multifocal tumors, the risk of having bilateral disease at some point in their life is pretty high. We see this most commonly with patients with papillary renal cell carcinoma. That is very often a multifocal and bilateral process. So if there's one thing I would recommend to the listeners today, multifocal tumors does not automatically equal radical nephrectomy.
So second sort of case, and I think you've touched on this a little bit, but maybe we'll just sort of bring it full circle one more time. Maybe a patient with a VHL germline mutation who is, let's say, already had a radical nephrectomy previously, and now they're coming to your practice. You recognize that they've got 2 small tumors in the remaining kidney, say they're 2 centimeters each. They've had a prior radical nephrectomy. You've sort of gone through the thought process and said, germline testing, you've identified they have VHL, and let's say they have even, an extra renal manifestation of VHL, say a hemangioblastoma of the spine. Well, talk to us a little bit about this scenario. Obviously, you're in a little bit of a pickle right out of the gate, because now you're down to a solitary kidney and you've got some small renal masses and they have a hereditary diagnosis. Your approach here and how you counsel the patients.
Yeah, no, that's one that we see fairly often too, and this is one that has changed in the last few years. 5 years ago, we would see this patient. We would plan in the next 1 to 2 years probably to do a partial nephrectomy. It's not yet 3 centimeters, but it's close and it's growing. Now this patient would be a great candidate for belzutifan. And why is that? they're at a higher risk situation from surgery because they're solitary kidney and they've got multiple tumors, but they also have this extra-renal manifestation. So again, the bang for your buck, I think, is greater here to try to treat both of these with belzutifan, realizing that the side effects of belzutifan, things like anemia, maybe some fatigue, is probably better tolerated in this situation than in someone who has two kidneys and nothing else going on.
And just to pick up on that point that you just made there, just educate our listeners. For those that have patients that are on belzutifan, talk a little bit about the AE side effects. I think you mentioned the anemia, which is probably important for our listeners to know. Maybe talk to us a little bit about that for a moment.
Yeah, absolutely. So the main side effect of belzutifan is sort of an on-target effect. Downstream of HIF is EPO. These patients have decreased EPO when they're on belzutifan, so they get anemic. Sometimes it can be quite profound, and it would require the treating physician to sort of do a dose reduction. But they all sort of have some degree of anemia. That's how you know they're getting adequate drug, to be honest. And along with that, some get quite fatigued. So again, it's fairly well tolerated, but they do have to be aware of those issues. Some patients need EPO to be replaced. Some need blood transfusions, but those are pretty rare.
And maybe the third case scenario is this patient with HLRCC who, let's say, has a small renal mass, 2 centimeters. And you see evidence of hilar or retroperitoneal adenopathy. Talk to us a little bit about your thought process when you see that. I think you mentioned it a little bit, that this, your spidey sense, I guess, is going off that this is a biologically aggressive entity. Talk a little bit about how do you manage this small renal mass at the same time with retroperitoneal adenopathy?
Yeah, again, this is a good case to just highlight that even setting aside the adenopathy for a second, HLRCC plus a renal mass, we're not going to do active surveillance. So this is someone who needs to be treated, and we would do a partial nephrectomy here, and we would do that again. We would use an open approach, take a wide margin, and then at the same time we would do an RPLND. This is sort of a different paradigm than other types of kidney cancer, where you can really move the needle and have prolonged sort of disease-free survival for localized, even regional adenopathy. These patients can do quite well with all the disease resected. Some will recur, sometimes years down the road, but we can really have prolonged disease-free survival in these patients.
And then, maybe last question I'll sort of ask you just as we close out this program is, obviously with the ubiquitous use of imaging, CT or MRI, CT often more common than MRI, we are detecting more renal masses. We're detecting more renal masses in younger patients. So the one question I would have, just practically speaking, let's just take a 40-year-old male or female who comes in with a 3 centimeter renal mass, and you've gone and you've done, say, your partial nephrectomy, and then you've done the germline testing. Talk a little bit about your surveillance and your follow-up for those that truly have a sporadic renal lesion but are young, and much younger than the average. And then obviously talk about how the germline testing impacts in those cases that are positive, and how you follow those, maybe those two scenarios.
Sure. For the patients where the germline is negative, but they're early onset, I tend not to discharge those patients from care completely. So we do sort of our standard oncologic follow-up that's guided by the guidelines and the path for that tumor until 5 years. But we don't sort of say see you never after that. We sort of still bring them back every 2 or 3 years just for a scan, because I've seen people who have had contralateral disease 10 years after their initial resection, don't know what's going on, what's causing that, and it's an active question, but I think they deserve some type of extended follow-up. Now, for patients who do have positive germline testing, then we sort of go down the algorithm for which gene they have. If it's for VHL, that sets off a multi-organ surveillance sort of system for their for the eyes, for the brain, for the pancreas, and depending on the on which syndrome we're talking about, we're going to follow those guidelines for both them, and then we're going to recommend that they talk to their family members, their first degree relatives, their siblings and children to also have testing.
And then, my final question on this is that let's take a patient who's gone for, say, let's just take an HLRCC patient. You didn't know they had HLRCC. You took them to the OR, you did a partial nephrectomy, then you went down the road and you obtained germline testing. Then you identified. What do you do now? So you've highlighted very clearly for us, this is a biologically aggressive entity. Your operative approach, if you knew this a priori right out of the gate, would be more aggressive. What do you do in these situations? And I'm sure you faced it where you get a referral after the fact, and now obviously you're in a situation where they have aggressive disease, and maybe the surgery right out of the gate, through no necessary fault, but through right out of the gate, was maybe not as aggressive as it had to be. What do you do in those scenarios? Do you reoperate right away, or do you put them on a tight surveillance regimen?
Yeah, I would go with the tight surveillance regimen here. I think there's little role to reoperate kind of prophylactically. Almost in any scenario in kidney cancer, positive margin, I'd want to see evidence, because sometimes the first resection is adequate. A lot of times it is.
Mm-hmm.
But I would follow those patients kind of every 3 months for the first year. And if things look great, then everyone can breathe a sigh of relief, and we can, relax the follow-up a little after that.
That's great. Well, Mark, has been a real pleasure getting a chance to chat with you, getting a chance to pick your brain a little bit on some of these hereditary kidney cancer entities. Obviously, even more importantly, how you think about managing them, because I think that's practically how a lot of us, I think, apply this into practice. So really have enjoyed the conversation. Really very much appreciate your time, especially late on a Friday afternoon here.
Pleasure is all mine. Thank you so much.
For our audience, please visit us at auanet.org/university. And as a side plug, Dr. Ball and Dr. Linehan always run a fabulous course at the annual meeting that really does dive into greater detail on some of the management nuances. And so for any that are interested in this topic, I would strongly encourage that you catch this course either next year, or certainly I think we have most of these live streamed to learn more. Mark, real pleasure. Again, big thanks. And I look forward to hopefully seeing you sometime soon.
Thanks again.